Hello everyone, I am myself Dr. 𝐒𝐽𝐻𝐫𝐢𝐚. I am the general medicine educator. So in this particular section, I'll be discussing the quick revision of the connective tissue disorders. So in the connective tissue disorders, the first topic for the discussion will be the rheumatoid arthritis. So if you take this rheumatoid arthritis, what exactly is the definition of the rheumatoid arthritis? It is an inflammatory disorder. It is an autoimmune disorder. Mainly you have the involvement of the small joints, and the involvement of the small joints, it will be symmetrical peripheral polyarthritis, right? It is symmetrical peripheral polyarthritis causing the joint damage and as well as the disability, right? So causing the joint damage and as well as the disability. So that is the definition of the rheumatoid arthritis. Now, what is the incidence of this rheumatoid arthritis? It is more common in women and the percentage is around 0.8%, right? So percentage is around 0.8%, and it is more common in women almost 3 times, right? So 3 times that of men. And what is the age group at which this rheumatoid arthritis is very common? The rheumatoid arthritis is very common in the age group of 4th to 5th decade, right? And commonly also observed in men as well, but in men it is around 6th to 8th decade. Now what exactly is the pathogenesis? So mainly it is the damage to the cartilage and as well as bone. So it involves the cartilage and as well as the bone resorption or bone erosion. And so this erosion of the bone and as well as the cartilage, it is via the inflammatory mediators. And in these patients with rheumatoid arthritis, one of the characteristic formation within the joint will be the pannus formation. And what does this pannus contain? It contains the inflammatory mediators, it contains the degenerated particles of the bone and as well as the cartilage. So that is about the pannus. Now what will be the clinical manifestations in these individuals? The very important is early morning stiffness. And this early morning stiffness will be there within the small joints, and that particular stiffness will be there for more than 1 hour. So that is a characteristic feature that you will have in the patients with the rheumatoid arthritis. And in the affected joints, what are the joints which are affected? Mainly the proximal interphalangeal joints, metacarpophalangeal joints, and as well as metatarsophalangeal joints. And in the joints which are being affected, you will have all the signs of the inflammation, right? You will have all the signs of the inflammation. Now, what are the signs of the inflammation? That is rubor, calor, tumor, and as well as the dolor. So this will be the signs of inflammation that will be there within the affected small joints. And please remember, you don't have the involvement of the distal interphalangeal joint. It is only the involvement of PIP, MCP, and as well as the MTP. And DIP involvement is observed in case of the osteoarthritis and as well as in case of the psoriatic arthritis. So these are the 2 conditions where you have the involvement of the distal interphalangeal joint, right? And you have to understand that in long-standing cases of the rheumatoid arthritis, there will be, right, in long-standing cases of rheumatoid arthritis, there will be deformities. And what are these deformities? These deformities include the swan neck deformity. So swan neck deformity in the sense where there will be hyperextension of the proximal interphalangeal joint, and there will be flexion of the distal interphalangeal joint, right? There will be flexion of the distal interphalangeal joint. That is what is the swan neck deformity. Then what is the Botaniad's deformity? Botaniad's deformity is exactly the opposite to that of the swan neck deformity. So Botaniad's deformity is that where there will be flexion at the level of the proximal interphalangeal joint, and there will be extension at the level of the distal interphalangeal joint. Okay, so that is what is the Botaniad's deformity. And the other important deformities that will be in the form of Z-shaped thumb and as well as ulnar deviation. So these are deformities that you observe in patients with rheumatoid arthritis. And do you have any spine involvement in rheumatoid arthritis? Spine involvement will also be there in rheumatoid arthritis, but that is mainly the cervical spine. And within the cervical spine, the vertebra which is being affected is the C1 and as well as C2 vertebra. That is atlantoaxial joint dislocation will be there, right? So there will be atlantoaxial dislocation, and due to atlantoaxial dislocation, these patients will have quadriparesis, these patients will have spasticity, these patients will have pain in the neck, and that will be radiating to the occiput. So that will be the spine involvement in patients with the rheumatoid arthritis. So there will be like occipital pain. And do they have any extra-articular manifestations? Yes, there will be also extra-articular involvement as well in patients with rheumatoid arthritis. And this extra-articular involvement, what is the most common extra-articular involvement? That will be in the form of subcutaneous nodules. And these subcutaneous nodules, they are present over the extensor aspect of the forearm. Right, these subcutaneous nodules, they are present over the extensor aspect of the forearm, and these subcutaneous nodules, they are non-tender. Right, they are non-tender. That is the most common extra-articular manifestation. And lung involvement will also be there in the form of the pleural effusion and as well as interstitial lung disease, and there will also be rheumatoid nodules. So this will be the respiratory involvement in patients with rheumatoid arthritis. And we have an important syndrome, right, and that is what is called as the Kaplan syndrome. Now, what is this Kaplan syndrome? It is rheumatoid arthritis plus the presence of lung nodules in the, right, the presence of the lung nodules. Okay, that is rheumatoid nodules. That is what is nothing but your Kaplan syndrome, right? Next. And the other important extra-articular manifestation will be in the form of ophthalmic involvement, that is scleritis, and as well as episcleritis will be there. And these patients with rheumatoid arthritis, they are also associated with the another important autoimmune disorder, that is 𝐒𝐼𝐻 syndrome, right? So this will be the extra-articular manifestation in patients with the rheumatoid arthritis. And you also have neurological involvement in these individuals, and this neurological involvement in patients with the rheumatoid arthritis will be in the form of the carpal tunnel syndrome and as well as the tarsal tunnel syndrome. So carpal tunnel syndrome is that where there is involvement of the median nerve or where there is compression of the median nerve, and tarsal tunnel syndrome is that where there is compression of the tibial nerve. Okay, and what is the cause of death in these individuals is mainly because of the cardiovascular involvement. So what will be the cardiovascular manifestations? The cardiovascular manifestations in rheumatoid arthritis will be in the form of the coronary artery disease, will be in the form of the mitral regurgitation, will be in the form of the premature atherosclerosis, and that will be resulting in the death of the individual. And death in the individual is mainly because of development of the congestive heart failure. So increased mortality is due to chronic inflammation that is causing premature atherosclerosis, coronary artery disease, and congestive heart failure, right? Then how do you work up these patients? See, RA factor will be positive, but remember the RA factor is non-specific. There are multiple other conditions where RA factor can be positive. Then what is the investigation of choice? Then the investigation of choice will be the anti-CCP. So anti-CCP, it is the specific investigation mainly for rheumatoid arthritis. And markers of the inflammation, that is ESR and as well as the CRP, they are also elevated. Then if you take the X-ray, right? So if you take the X-ray in these individuals, definitely there will be joint erosions. Apart from the joint erosions, these patients will also have a periarticular osteopenia, right? There will be periarticular osteopenia. So these will be the X-ray manifestations in patients with the rheumatoid arthritis. And these signs of the inflammation within the joints, they are mainly within the small joints, and that particular small joints that include metacarpophalangeal joint and as well as the proximal interphalangeal joint. And next important is the MRI. What the MRI will show you in these patients with rheumatoid arthritis is the MRI will show you that there is presence of tenosynovitis. Right, MRI will show you that there is presence of tenosynovitis, and the tenosynovitis, it's a very, very important feature in patients with the rheumatoid arthritis, right? Then how do you treat these patients? See, you need to give the treatment for acute attacks and you need to give the treatment for the maintenance therapy as well. Now, what is the treatment for the acute attack? So the treatment for acute attack will be mainly the NSAIDs, right, or the steroids. Right, NSAIDs or the steroids. So that will be the drugs for the acute attack, right? That will be the drugs for acute attack. But what are the drugs that we give as a part of the maintenance? The drugs that we give as a part of the maintenance will be DMARDs, that is disease modifying anti-rheumatic drugs. And among the disease modifying anti-rheumatic drugs, what is the drug of choice? The drug of choice will be methotrexate, right? Methotrexate is a drug of choice. And then we have a triple therapy in the treatment of the rheumatoid arthritis. And what is the triple therapy in rheumatoid arthritis is methotrexate plus sulfasalazine plus hydroxychloroquine. So these three together constitute what is called as triple therapy. Or the other combination which is very much effective is methotrexate plus leflunomide. Even this combination also works better. Now, if these combinations are not working, if the patient is having the signs of inflammation in spite of these combinations, then the individual has to use the biological drugs. And what are these biologicals? That is the TNF alpha inhibitors, and the examples of them are the abatacept and as well as the rituximab. So these are the biologicals. And apart from this, we also have the Janus kinase inhibitors. And what are the examples of these Janus kinase inhibitors? The examples are the tofacitinib and as well as baricitinib. So these are the examples of the Janus kinase inhibitors. So these are the medications that we give in the treatment in the patients with rheumatoid arthritis. And complications, as already I have discussed, it is mainly the cardiovascular disease that will be responsible for death of the individual in patients with the rheumatoid arthritis. So this is about the rheumatoid arthritis in brief. Okay. Now, after having discussed about the rheumatoid arthritis, the next important topic for the discussion will be the ankylosing spondylitis. Now, if you take this on ankylosing spondylitis, what type of arthritis is this? This is a seronegative arthritis. Right? So this is a seronegative arthritis. So what do you understand by this word seronegative arthritis? In the sense, the RA factor will be negative. Right? The RA factor will be negative. That is what you observe in case of the ankylosing spondylitis. And you need to know that ankylosing spondylitis, it is also a chronic inflammatory disease. Right? And what are the joints which are commonly affected in patients with the ankylosing spondylitis? The joints which are commonly affected is the spine, and as well as you have the involvement of the sacroiliac joint. Right? There is involvement of the spine and as well as the sacroiliac joint. And because of the involvement of the spine, there will be stiffness within the spine. And because of the involvement of the sacroiliac joint, there will be pain within the hip region, or there will be pain in the sacroiliac area. So that is what is the problem in patients with the ankylosing spondylitis. And as I have said you, this ankylosing spondylitis, it is a form of the seronegative arthritis. And what are the other examples of the seronegative arthritis? That includes the mnemonic as PAIR. P stands for psoriatic arthritis, A stands for the ankylosing spondylitis, I stands for the inflammatory bowel disease, R stands for recurrent or reactive arthritis. So, right, these are the conditions where you have seronegative arthritis. Now, if you take the important associations, all these patients with seronegative arthritis, they have the HLA-B27 being positive. And you need to be aware of what is the age group at which this ankylosing spondylitis is being very common. This is very common at the age of the 40 years. And what will be the presentation in these individuals? It is mainly because the spine involvement is there, and that too low back. So the spine involvement will be from low to up. So initially you have the involvement of the lumbosacral spine, followed by that there will be involvement of the thoracic spine, and followed by that there will be involvement of the cervical spine. So these patients, they present with inflammatory back pain. So these patients, they present with pain in the low back, and there will also be early morning stiffness, right? And this pain in patients with ankylosing spondylitis will be excess in the night. So that we consider it as the nocturnal pain. And these patients will also have the chest tightness and as well as reduced spinal mobility, right? And this particular reduced spinal mobility is mainly due to fusion of the vertebra, right? It is due to fusion of the vertebra, you have the reduced spinal mobility. So there is loss of spinal mobility. Now, how is that you will examine for this spinal mobility? By doing a test called the Schober's test. And Schober's test will demonstrate that the spinal mobility is reduced, and that is due to fusion of the vertebra. So that is the very important test that we do in case of the ankylosing spondylitis. And these patients, they will also have the restricted chest expansion. There will also be enthesitis. What do you understand by the word enthesitis? The enthesitis means it is the inflammation of the tendon at the point of insertion over the bone, right? Inflammation of the tendon at the point of insertion over the bone, that is what is called as the enthesitis, right? And these patients will also have the ocular manifestation, and this ocular manifestation will be in the form of anterior uveitis. And this anterior uveitis, this is considered as the most common extraarticular manifestation in patients with the ankylosing spondylitis. And what are the cardiac involvement in patients with ankylosing spondylitis? That will be in the form of the aortic regurgitation. This will be in, there can also be development of the complete heart block. And because of the complete heart block, these patients, they usually present with bradyarrhythmias. Right, these patients, they present with bradyarrhythmias. So this will be the clinical signs that you observe in patients with ankylosing spondylitis. So in ankylosing spondylitis, please remember, articular involvement will be in the form of spine and sacroiliac joint. Extra-articular involvement will be in the form of the anterior uveitis, aortic regurgitation, complete heart block, and these patients will also have the enthesitis and restricted chest expansion will be there. Now, when you do a radiological examination, the very important X-ray finding will be in the form of the bamboo spine. Right, so there will be squaring of the vertebra, and the squared vertebra, they fuse together, right, and that is because of the calcification of the interspinous ligaments, and that will give you a picture of the bamboo spine. And there will be pseudo widening of the joint spaces, there will be squaring of the vertebra. And when you do MRI in these patients, the MRI will show you that there is presence of the bone marrow edema, And what is the most common extra-articular manifestation? The most common extra-articular manifestation will be in the form of the anterior uveitis. And cardiac manifestation will be in the form of aortic insufficiency. There can be development of the complete heart block. And the other important is the inflammatory bowel disease, right? And what are the investigations? The investigations, as I have said you, the important investigation is the ankylosing spondylitis is having an association with the 𝐻LA-B27 that is being positive. And what are the markers of the inflammation? That is the CRP, that will be elevated. And it is seronegative arthritis, so the RA factor will be negative. So the important radiological findings are observed in the X-ray and as well as the MRI. Right, the important radiological findings are observed in X-ray and as well as the MRI. Now, what is that which will demonstrate the severity of the ankylosing spondylitis? So that is serum matrix metalloproteinase, right, serum matrix metalloproteinase. So this is the one which will tell you about the severity of the ankylosing spondylitis. And in patients with ankylosing spondylitis, what is the cause of death? The cause of death in patients with the ankylosing spondylitis will be fracture of a rigid osteoporotic spine. Right, fracture of the rigid osteoporotic spine. That will be the cause of death in patients with the ankylosing spondylitis, right? Now, if you take the diagnostic criteria, that is the ankylosing spondylitis criteria, it includes number one, the 𝐻LA-B27 should be positive. Along with the 𝐻LA-B27 being positive, the imaging, and what is that imaging? MRI and as well as the X-ray. X-ray will show you that there is bamboo spine, right? And there will be pseudo widening of the joint spaces. And there will be clinical features of the spondyloarthritis, right? Clinical features of spondyloarthritis. So this will be the diagnostic criteria. Then how do you treat? What exactly is the drug of choice in patients with ankylosing spondylitis? See, the drug of choice in patients with ankylosing spondylitis will be indomethacin. So indomethacin is considered as the drug of choice, right? And with indomethacin, if the individual does not have an adequate response, then you need to add the biological agents, that is anti-TNF agents, right? And you need to be very much aware of an index called, that is the 𝐵ASDRA index, that will tell you about the disease activity by using a scale of 0 to 10. And in this particular scale of 0 to 10, what are the symptoms which are taken? Fatigue, spinal pain, arthralgia, and as well as stiffness. If the score is more than or equal to 4, right, if the score is more than or equal to 4, this will suggest that the individual has a poor disease control, and this particular patient will need the treatment adjustment or the biological therapy is required, and that is what is called as the 𝐵ASDRA index. So if it is more than 4, that means the individual is not having an adequate response to the indomethacin. Then what are the complications? One is spinal fusion, that is bamboo spine. Next is the cardiovascular issues, that is in the form of the aortic insufficiency and heart block, and there will be reduced quality of life in patients with the ankylosing spondylitis. So this is about the ankylosing spondylitis. So important features are what? Spine involvement, sacroiliac joint involvement, extra-articular involvement mainly will be in the form of the anterior uveitis, cardiovascular involvement will be in the form of complete heart block and aortic regurgitation, and marker which will tell you about the disease activity is serum matrix metalloproteinase, and spinal fusion can be made out by your spinal fusion is made out by the Schober's test, and BASDA index is the one which will tell you about the disease activity and response to the treatment, right? Now, after having discussed about the ankylosing spondylitis, the next important topic for the discussion is the Rheumatoid syndrome, which is also called as reactive arthritis. Now, this Rheumatoid or reactive arthritis, there are three important features. They are characterized by a triad, that is arthritis, urethritis, and as well as the conjunctivitis. So these three are the important components of Rheumatoid, which is also called as the reactive arthritis. And this particular Rheumatoid or reactive arthritis, it is precipitated by gastrointestinal or genitourinary infection, right? Precipitated by gastrointestinal or genitourinary infection, right? Now, if you take this particular arthritis in this individual, it will be asymmetrical arthritis, right? It is not symmetrical what we see in case of rheumatoid arthritis. Here it is asymmetrical arthritis, and that too the joints of lower limbs are commonly affected. That is very, very important. And because it is a form of seronegative arthritis which is having HLA-B27 being positive, even these patients, they have an association with the enthesitis, right? And the triad, that is the arthritis, urethritis, and as well as the conjunctivitis. So what is the HLA association? These patients, they have a very strong association with the HLA-B27. Strong association with HLA-B27. Then what are the common triggers? So I said you there should be a preceding gastrointestinal or the genitourinary infection. So preceding gastrointestinal infection, it is caused by Shigella, Salmonella, and as well as the Campylobacter. Whereas preceding genitourinary infection, it is caused by the Chlamydia trachomatis, right? But between these two, which is the most common, which will be responsible for the development of the Rheumatoid is, it is the genitourinary, right? It will be genitourinary, that will be more common than compared to that of the gastrointestinal infection. And if you take this Rheumatoid, like if you take the incidence wise, is it common in men or women? Please remember, this is more common in men, right, than compared to that of women. And as I have said you, like the HLA-B27 will be positive in these patients. Then what are the key symptoms? The key symptoms is oligoarthritis, and that too the involvement of the joints of the lower limbs, right? And there will also be enthesitis as well. Now, apart from this arthritis, urethritis, and as well as conjunctivitis, these individuals will also have the skin involvement, and that skin involvement will be in the form of Scleroderma blennorrhagica, right? What do you understand by this word Scleroderma blennorrhagica? Scleroderma blennorrhagica is nothing but the presence of hyperkeratotic vesicles over the palm and as well as the sole of the foot. That is what you mean by the word Scleroderma blennorrhagica, right? And these patients, they also have the mucocutaneous ulcers as well. So these are the manifestations in patients with Rheumatoid or reactive arthritis. And then how will you work up these patients? One important thing is the HLA-B27 will be positive, right? So one important is the HLA-B27 will be positive. And apart from that, you need to take the cultures. So where all you need to take the culture from? Okay, so you need to take the culture from the urethra, cervix, throat, or you need to take the culture of the urine and as well as the stool. So cultures, they are the very important part of the workup in patients with Rheumatoid or the reactive arthritis. And next is clinical presentation, arthritis, urethritis, and conjunctivitis. And this particular arthritis, it is asymmetrical, and that to the joints of the lower limb. Then how will you treat these patients? So for arthritis, what is the first line treatment? The first line treatment for arthritis will be the NSAIDs, that is non-steroidal anti-inflammatory drugs. Then these patients will also be requiring the antibiotics mainly to treat the gastrointestinal or genitourinary infection. So the one which is effective in acute infection, it is mainly we give doxycycline. Okay, that is mainly for Chlamydia trachomatis, we give doxycycline. And apart from this, DMARDs, that is disease modifying anti-rheumatic drugs, sulfasalazine, or methotrexate. Sulfasalazine or methotrexate has to be given for the NSAID resistant cases. See, for arthritis actually we give NSAIDs. But if the individual is resistant to the NSAIDs, then you need to give methotrexate or sulfasalazine has to be given, right? Now, biologicals. So what are these biologicals? Biologicals are the TNF alpha inhibitors, that is anti-TNF agents, and these anti-TNF agents, they are given in cases of refractory conditions, right? They are given in cases of refractory conditions, okay? So that is about the treatment in patients with the recurrent or reactive arthritis. Then you take the skin manifestations, that is in the form of Scleroderma blennorhagicum, that is hyperkeratotic vesicles in the palm and as well as the sole of the foot, right? And what is the prognosis? It usually resolves, but chronic or recurring arthritis may occur in some patients. So this is about the recurrent or the reactive arthritis, right? Which is characterized by the presence of a triad. Done? Now, after having discussed about the recurrent or the reactive arthritis, the next important topic is the SLE, right? That is systemic lupus erythematosus. So this is an autoimmune condition. Multiple systems are being affected. Multiple autoantibodies are there. But these autoantibodies, please remember, they are mainly against the nuclear and as well as the cytoplasmic component. Okay, nuclear and as well as. So these antibodies will go and combine with the antigen in the body, and there will be formation of the immune complexes. And it is the immune complexes that will be creating the problem in multiple organs. Because it is immune complex mediated disorder, we consider this as a type 3 hypersensitivity reaction. What are the key symptoms, right? What are the most common symptoms? In almost 95% of patients, the individual will be presenting with this fatigue, malaise, fever, and as well as arthralgia. That is the most common symptoms in these individuals, right? And apart from that, next is the mucocutaneous manifestations. So the cutaneous manifestations will be in the form of malar rash, discoid rash, and as well as the photosensitivity, right? And this particular photosensitivity, how do we treat this photosensitivity? We treat that with the help of the hydroxychloroquine, right? And the mucocutaneous manifestation will be in the form of the oral ulcers, and then there will be non-erosive arthritis. Okay, it will be non-erosive arthritis. That is what you will observe in patients with the systemic lupus erythematosus. Then, if you take the skin manifestations in these patients, the skin manifestations will be in the form of malar rash, that is the fixed erythematous rash that is mainly over the malar eminences and as well as the sun exposed areas. And next important is the discoid rash. And this particular discoid rash, it is erythematous, circular, raised patches, right? Erythematous, circular, raised patches with scaling, follicular plugging, and as well as the atrophic scarring. That will be the discoid rash. And photosensitivity, it is triggered by the sunlight exposure. And the oral ulcers, they are painless. Very important, painless. But what is the condition where you have recurrent painful ulcer, that is aphthous ulcers within the oral cavity? You will see that in case of Behçet's. In case of Behçet's, it's a painful ulcer. Whereas in SLE, the ulcers that you have in the oral cavity, it is the painless ulcer. And these particular ulcers, they are often distributed over the hard palate or the buccal cavity, right? They are mainly distributed over the hard palate and as well as the buccal cavity, right? Now, coming to the organ involvement. So if you take the organ involvement, multiple organs are affected apart from the skin. What are those organs? So skin involvement already we have discussed, that is in the form of the malar rash, discoid rash, then photosensitivity, and then the oral ulcer. Joint involvement, that is non-erosive arthritis. Kidney involvement, if you see in patients with SLE, that is in the form of lupus nephritis, right? So these patients, they develop a form of nephritic syndrome. So presentation can be in the form of hematuria. Presentation can be in the form of the proteinuria as well. That will be the kidney involvement. And in the lupus nephritis, there are totally 6 classes, and the characteristic biopsy finding or characteristic pathological lesion will be wire loop lesion, right? Characteristic biopsy lesion will be wire loop lesion. So that is what you observe within the kidneys. Next is the cardiovascular involvement. So cardiovascular involvement will be in the form of pancarditis, right? Cardiovascular involvement will be in the form of pancarditis. Okay. Now in the pancarditis, you need to know that there is pericarditis, myocarditis, and as well as the endocarditis, right? Pericarditis, myocarditis, and as well as the endocarditis. So if you take this pericarditis, pericarditis will present in the form of chest pain. Myocarditis will present in the form of the heart failure and as well as dyspnea. Right? Endocarditis, this will present in the form of Liebman-Sachs endocarditis, where you have the valvular involvement. Okay, so that will be pancarditis. Next, pulmonary involvement. So pulmonary involvement will be in the form of the interstitial lung disease. Pulmonary involvement will be in the form of the pleural effusion. And one of the rare manifestation in patients with the SLE, the lung involvement, is shrinking lung syndrome. Right, shrinking lung syndrome. So shrinking lung syndrome, it is due to diaphragmatic myopathy, where antibodies are formed against the diaphragmatic muscles. That is what is called shrinking lung syndrome. CNS manifestations will be in the form of lupus cerebritis, seizures, and as well as psychosis. And hematological manifestations will be in the form of the pancytopenia, right? And what will be that pancytopenia? That is anemia, leukopenia, and thrombocytopenia. So this will be the hematological manifestation. So these are the multiple organs which are affected. So if you take the renal involvement, that will be in the form of lupus nephritis. And as I have said you that there are totally 6 classes. Out of these 6 classes, the characteristic lesions will be wire loop lesions. That is what you observe on the biopsy, right? And the most severe is class 4, which is considered as a diffuse lupus nephritis, right? Which is considered as diffuse lupus nephritis, right? And the cardiac features will be in the form of pericarditis, that is most common, then myocarditis and Liebman-Sachs endocarditis. So Liebman-Sachs endocarditis, where you have the valvular involvement, and whenever there is valvular involvement, the patients usually, when it is pericarditis, you can treat by giving methylprednisolone or steroid. But if it is valvular involvement, that is Liebman-Sachs endocarditis, the steroids will not work. You need to do a valvuloplasty. And these patients, they have the increased risk of atherosclerosis and as well as the vasculitis. So this will be the cardiac feature in patients with the systemic lupus erythematosus. Pulmonary manifestations will be in the form of pleuritis, that is the one which will result in chest pain, pleural effusion, alveolar injury. Shrinking lung syndrome is another important manifestation, but that is a rare manifestation. And CNS, as I have said you, seizures and as well as psychosis, cognitive impairment, and lupus cerebritis. Now, what are the antibodies? The antibodies for the CNS manifestations are the anti-RNP antibody, and the other one is the anti-neuronal antibody. Hematological, as I have said you, pancytopenia. Autoimmune hemolytic anemia will be there, right? And because this autoimmune hemolytic anemia is observed, these patients said to be 𝐒𝐮𝐬𝐜𝐵 positive hemolytic anemia, right? 𝐒𝐮𝐬𝐜𝐵 positive hemolytic anemia. And these patients will also have the thrombocytopenia and APLA syndrome, right? APLA syndrome, that is anti-phospholipid antibody syndrome. Okay, so now these APLA syndrome, you need to understand that if the APLA antibodies are positive, then these patients, they are at increased risk of the thromboembolism. So there will be hypercoagulability. These patients will have hypercoagulability. Okay, so this hypercoagulability is the one that is responsible for increased risk of abortions in these patients with the APLA. And these patients with APLA, they have increased risk of the pulmonary thrombosis and deep vein thrombosis and thrombus formation at multiple sites. So this will be the hematological involvement. Now, what will be the immunological markers? The immunological markers, as I have said you, that is mainly the antibodies. What is the most specific antibody? Most specific antibody will be anti-Smith, right? So anti-Smith, it is the most specific antibody, right? And then what is the most sensitive antibody? Most sensitive antibody will be anti-nuclear antibody. This will be the most sensitive antibody, right? And the antibody which will tell you about the CVRT will be anti-dsDNA. So anti-dsDNA, it is the most, it is the antibody which will tell you about the CVRT, right? Then we have anti-RNP antibody, that is mainly responsible for the CNS lupus, and anti-Rho. This will be responsible for the neonatal lupus, where the neonates can present with the complete heart block. So these anti-Rho antibodies, they can cross the placenta, right? By crossing the placenta, they can cause the neonatal heart block, right? And these anti-Rho antibody, they are also responsible for the development of photosensitivity as well. And APLA antibodies, what are the examples? So if a patient with SLE has APLA, there is increased risk of thrombosis. And what are the antibodies of APLA? That includes the lupus anticoagulant, then anti-cardiolipin antibody, and as well as anti-beta-2 glycoprotein, right? Lupus anticoagulant, then anti-cardiolipin antibody, anti-beta-2 glycoprotein. Now, the next important antibody is in the drug-induced lupus. In drug-induced lupus, the antibody will be anti-histone antibody, right? It is the anti-histone antibody, that is what is observed in case of the drug-induced lupus. And please remember, what is the most common drug that is responsible for drug-induced lupus? It is procainamide, which is class 1 anti-arrhythmic drug, right? And apart from this procainamide, the other drugs are the hydralazine, which is an arteriolar vasodilator, then isoniazid, which is an anti-tubercular drug. So these are the antibodies that will be responsible. These are the drugs which will be responsible for drug-induced lupus. And if you take the criteria, the name of the criteria is European criteria, that is EULAR, or American criteria for rheumatology, that is ACR. So according to this criteria, how will you make up the SLE is, there should be a combination of clinical, immunological finding. And within the immunological finding, this should include ANA, anti-dsDNA, and the specific organ involvement. So this will be the EULAR or ACR criteria for systemic lupus erythematosus, right? And how do you treat these patients? Mild cases of SLE, you can give non-steroidal anti-inflammatory drugs and as well as the hydroxychloroquine. So mainly this hydroxychloroquine we give in the treatment for photosensitivity. Right? And NSAIDs mainly for arthritis. But for moderate to severe cases of the systemic lupus erythematosus, we give glucocorticoids. And if the individual is not having an adequate response to the glucocorticoids, then we need to give the immunosuppressants, and these immunosuppressants include mycophenolate mofetil and as well as the cyclophosphamide. Then how do you treat the cutaneous involvement, that is the photosensitivity? So first and foremost, avoid the sun exposure. Hydroxychloroquine should be given, and then the corticosteroids. And for the treatment of the psychosis, you need to give antipsychotics, that is haloperidol has to be given. Right, haloperidol has to be given. And for 𝐒𝐵𝐴 endocarditis, what did I tell you? You need to do a valvuloplasty. These patients, they do not respond to the steroids, right? And how do you consider these patients having the prognosis? What is the common cause of death? Because these patients have neutropenia, the common cause of the death will be infections, right? And in early cases of the SLE, renal failure contributes to the mortality. In the later cases of the SLE, thromboembolic events contribute to mortality. And the cardiovascular involvement also, because it's a chronic inflammatory pathology, these patients, they are at increased risk of a premature atherosclerosis. And this premature atherosclerosis is the one which will cause the coronary artery disease, and that will be responsible for mortality in patients with the SLE. So in case of SLE, it's a chronic inflammatory disease, multiple system involvement, autoimmune disorder, multiple antibodies, right? Multiple antibodies, out of which the most specific will be anti-Smith, most sensitive will be anti-nuclear antibody, and the one which will tell you about the CVRT is anti-dsDNA. And apart from that, we have drug-induced lupus, anti-histone antibody, photosensitivity, anti-Rho antibody, neonatal lupus, that is anti-Rho antibody, and for CNS lupus, that is anti-neuronal and as well as anti-RNP antibody. And for drug-induced lupus, it is anti-histone antibody. So multiple antibodies is what you need to remember. And majority of the scenarios we give steroids, but steroids are not useful in scenario of 𝐒𝐵𝐴 endocarditis. Steroids will not be of much use whenever there is the psychosis. In case of psychosis, you need to give haloperidol, right? So you need to be very much aware, like when to give steroids and when not to give steroids in patients with the SLE. So this completes the quick discussion related to the systemic lupus erythematosus, right? Now, after having discussed about the SLE, the next important topic for the discussion will be the Sjögren's syndrome. So Sjögren's syndrome, this is also an autoimmune disease, right? Multiple systems are being affected, but the common is the glandular involvement. And what are the common glands which are affected? That is lacrimal glands and as well as the salivary glands. So because of the involvement of the lacrimal glands, there will be dryness of the eyes, right? And due to the involvement of the salivary glands, there will be dryness of the mouth. So this is a systemic autoimmune disorder which is characterized by dryness of eyes and as well as dryness of mouth. So this we call it as 𝗓𝐜𝐼𝑡𝑖𝑠 right? This we call it as 𝗓𝐜𝐼𝑡𝑖𝑠, so where there will be dry eyes and as well as dry mouth. And this is the disorder where you have immune mediated destruction of the lacrimal and as well as the salivary glands, right? And if you take the epidemiology of this Sjögren's syndrome, it commonly affects the women. Because this is an autoimmune disorder, this is commonly observed in women, right? And ratio is almost 9:1. And what is a common age group at which you see this Sjögren's syndrome? This is commonly observed in the age of the 40 to 60 years. Now, because this is an autoimmune disorder, what are the cells which will be infiltrating into the gland? So it is the one which is characterized by lymphocytic infiltration of the gland, right? It is a disorder which is characterized by lymphocytic infiltration of the gland, where there will be infiltration of the CD4 plus T lymphocytes, right? Where there will be infiltration of CD4 plus T lymphocytes. And these particular lymphocytes, they produce the antibodies, that is anti-Rho and anti-La antibodies. And these antibodies, they are the one which will destroy the glands. And once they destroy the glands, there will be dry eyes and as well as dry mouth. So that is the pathogenesis that you observe in patients with the Sjögren's syndrome. Now we have two important forms of Sjögren's, that is primary and as well as the secondary form of the Sjögren's. So the primary form of Sjögren's, it is an isolated. That means only Sjögren's will be there in case of the primary form, and that we call it as the 𝐒𝐼𝐻 syndrome. Whereas secondary form of the Sjögren's is that which is associated with the other autoimmune disease. What are the other autoimmune disease? Like rheumatoid arthritis, systemic lupus erythematosus, scleroderma, and then primary biliary cholangitis. So what are the key symptoms? Because there is destruction of the lacrimal and as well as the salivary gland, these patients, they present with dry eyes, dry mouth, and there will be parotid gland enlargement. And parotid gland enlargement is observed in almost 50% of patients. Now because of the dry eyes, these patients, they will have burning or the itching sensation within the eyes. And these patients, they also have difficulty in swallowing the dry food, and that is mainly because of the dryness of the mouth. And these patients will have dental caries because there is no salivary secretion, loss of taste and smell, dryness of throat, and there will be destruction of the Bartholin's glands in these individuals, and that is the one which will be responsible for dryness of vagina, and that we call it as the dyspareunia, right? And because of the dryness of the vagina, these patients will have dyspareunia, right? Where they will have a painful sexual intercourse, right? Where they will have a painful sexual intercourse. So that is what is nothing but the dyspareunia, and that is due to dryness of the vagina. Now, apart from glandular involvement, there is also extraglandular involvement as well. What is the most common extraglandular involvement? That will be in the form of arthritis. And as we observe in case of systemic sclerosis, even these patients with the Sjögren's syndrome, they have the Raynaud's phenomena. And apart from that, these patients will also have vasculitis and as well as the peripheral neuropathy, right? And the lung involvement will be in the form of the interstitial lung disease, and kidney involvement will be in the form of renal tubular acidosis, that too type 1 renal tubular acidosis. And these patients with Sjögren's syndrome, they are at increased risk of development of lymphoma, that is low grade marginal B cell lymphoma. So this will be the extraglandular involvement. Coming to the autoantibodies. So the primary autoantibodies will be anti-Rho and anti-La, which is nothing but SSA and as well as SSB. Now, apart from these two antibodies, even you have an association with other connective tissue disorder or other autoimmune disorder. These patients will also have rheumatoid factor and as well as the anti-nuclear antibody will be positive. Then how do you work up for these patients with the Sjögren's? So the workup in patients with the Sjögren's, how will you check for the tear secretions? You will be able to check for the tear secretions by Schimmer's test. So Schimmer's test is the one which will measure the tear production. If the tear production, if it is less than 5 mm in 5 minutes, then the Schimmer's test is considered to be positive. The other one is the cylometry. So the cylometry is the one which will help in assessing the salivary secretion. Okay, so this will measure the salivary flow. If the salivary flow is less than 1.5 ml in 15 minutes, then the cylometry is considered to be positive, right? Then when you do a labial biopsy, so this is the most sensitive and specific test, and with this we consider it as the investigation of choice. So when you do a labial biopsy, this will show that there is lymphocytic infiltration. So CD4 plus T lymphocytes will infiltrate into the gland, and they will be producing the antibodies, that is anti-Rho and anti-La, and they will be destroying the glands. Okay, so lymphocytic infiltration of the gland will be there. Now, what will be the differential diagnosis? This includes the sarcoidosis, IgG4 related disease, HIV related 𝐒𝐼𝐫, and medication side effects. So this will be the differential diagnosis of the 𝗏𝐺REN syndrome. Then how do you treat these patients with the 𝗏𝐺REN syndrome? So the treatment of the 𝗏𝐺RENs is symptomatic treatment first. There is dry eyes, so you need to give the artificial tears and as well as personal lubricants, mainly in females with the dry vagina. And cyclosporin can be given for dry eyes, pilocarpine or cevimeline for xerostomia. Right, so these patients, they have dry mouth as well. So how do you treat that dry mouth? That is by pilocarpine or cevimeline should be given. Then what are the drugs for systemic manifestations? Most common extraglandular manifestation is arthritis. So you need to give NSAIDs, or you need to give corticosteroids if the patient does not respond to the NSAIDs. And the other important group of drugs are the immunosuppressants, and that includes rituximab for severe cases. Right, rituximab for severe cases. So this is what is the treatment in case of the 𝗏𝐺REN syndrome. So glandular and as well as the extraglandular involvement. Prognosis. See, quality of life, it is significantly affected in these patients because there is dry mouth, there is dysphagia, dry eyes, so there will be burning and itching sensation within the, or sand-like sensation within the eyes. So quality of life is significantly affected, but the lifespan, it is usually normal, right? Then when will you consider that this patient is said to be having poor prognosis? Poor prognosis will be there when there is systemic involvement.